So we have Dr. Lelio Baldeschi here. He's the president of the GOGO. Lelio, we had a nice talk from you in World Congress of Ophthalmic Plastic and Aesthetic Surgery in Dubai. So what's new? What was your actual lecture?
Well, we have saw a lot of new drugs that has been presented, and of course in a setting like this, we have also to consider what is possible and what is convenient for the third world or for the developing country. In this perspective, we have analyzed the benefit and the limitation of old and new treatment.
So what's your suggestion for our colleagues over the world? What kind of the treatments should be considered as the first line for patients that have active, moderate to severe thyroid eye disease?
Well, I think cost effectiveness, still steroids are the number one in the line. Of course, in developing country, we have to consider oral steroids, despite the well-known side effect. In a setting where it's possible to administrate intravenous glucocorticoids, that is the preferred route, as there is indeed some toxicity, but there is no side or only a few side effects. And toxicity can be prevented by keeping the dosage below 7.5 grams.
Okay. So some of our colleagues are asking if they should go for the new treatments, new drugs. So, and how do you answer these colleagues?
Well, we should always be open to new treatment, never be the first, never be the last. That is the most prudent policy. At the moment, for the so-called new treatment, long-term results are missing, and also not inferiority study are missing. There are indeed approval only in the North America. I'm speaking about new biological that are, let's say, well known to everybody. In Europe and in the rest of the world, these treatments are not approved. I'm not saying that they are not functioning, because there is very much rationale in blocking the culprit antigen that starts the chemotactic gradient arriving at the end at the deposition of glucosaminoglycans and amplification eventually of the fat compartment. But still, long-term results are missing investigator-driven studies, and not inferiority study is a must.
And you showed us a very beautiful actual presentation about differential diagnosis of the thyroid eye disease and the diseases that can be concomitant with patients with already having a thyroid problem. So how our colleagues should work up the cases, and how should they differentiate thyroid eye disease from imitating conditions?
Thank you very much for this question that gives me the possibility to promote our category. Orbital surgeon, or anyhow expert in orbital disease, are the first line in the diagnosis of grave cerebritopathy. Of course, also our good friend endocrinologist can help, especially when there is a confirmed diagnosis of grave cerebritopathy. But just to arrive at that point is necessary to operate a selection of patients, and very often other orbital disease present with the same characteristic. In reality, the major signs and symptoms of grave cerebritopathy, like lid retraction or exophthalmos, are shared by many other diseases. And especially if we are dealing with monolateral cases, divergent strabismus, and with absence of lid retraction, the diagnosis of euthyroid grave cerebritopathy is very suspect.
Thank you, Lelio. Thank you very much for your time.
Thank you to you.
See you soon.
Thanks.
Bye-bye.